So I think we all can agree that we would like to see everyone healthy and accessing affordable care. This panel is going to share what they are doing to make this possible for their employees and the clients that they serve. So we have with us John Hoffman. John is currently the head of healthcare policy and advocacy for the strategic customer group at J&J North American Pharmaceuticals. His responsibilities include ensuring unencumbered access to all J&J NA Pharma products for patients and physicians. The strategic customer group develops strategies and marketing programs for both public and private payers. John possesses over 30 years of broad experience at J&J, including finance, managed care marketing, e-business, and corporate strategy. And then I also have the other John with me today, John Butler. And John is manager benefit design for Edward Elmhurst Health, a nonprofit 3-hospital system in the southwest suburbs of Chicago. He joined EEH in 2005 and is responsible for the health and welfare benefits, as well as the wellness program for over 8,400 employees and their family members. Next slide. This should come to John Hoffman.
Yes.
Yes, it does.
Oops. There we go. So thank you, Denise, and I appreciate the kind introduction and the opportunity to be in front of this great group. And what I want to do this afternoon is talk about some things that we are trying to create awareness around that the impact of drug pricing on patient, or in this case, employee out-of-pocket costs, and what are all the contributing factors, and what are some of the hidden barriers to access that fall into that. So as you may know, Janssen, J&J, was the first company several years ago, I believe it was 5 years ago, to issue a transparency report, because we wanted to start creating awareness that drug list prices were not necessarily what was driving out-of-pocket costs, and that the way the healthcare system worked in this country with rebates, and many of you know as employee benefit experts, rebates are collected by health plans and pharmacy benefit managers, and some of them are passed on to you as employers, some of them are not. And then depending on the benefit design of the plans that your employees choose, they may or may not be passed on to the patient or the employee out-of-pocket costs. So, we were given a lot of, positive feedback for starting to create that transparency that showed how much we spent on our research and development and sales and marketing, et cetera. And so we've been continuing that, but this year we really wanted to take it to another level. We wanted to really help people understand, because I think it's been successful and most other pharma companies are now doing this, showing that our net prices are really going down, even though patient or employee out-of-pocket costs aren't going down. But what are some of the other factors that are happening kind of behind the scenes, and some things that even in discussions with our own J&J employee benefit experts, they weren't even aware of things that would happen that would restrict access and choice for our employees. And they've now made some changes to our contracts with our health plans and PBM. So next slide, please. There we go. So at J&J and Janssen, we are committed to affordable access for patients, and we recognize we have a responsibility and we play a role in that with our pricing decisions, and we'll talk about that as we go through this. But our real focus is to really create a future where disease is a thing of the past. That may sound counterintuitive because, well, if there's no disease, then you're not going to sell any products. But if you talk to the scientists, and I've met so many of them, they are really committed to a world without disease. And all of that means is that we want to create a healthier future for all as we move on that journey towards that world without disease. And so we want to talk about the things we're doing. Hopefully you see with the vaccine you know, the impact of research and development and innovation and how quickly the science can come to play and the technology can come to play to solve a global pandemic issue. And that's just a recent, you know, obviously top of mind example of the great science and innovation and discovery that's going on every day to people who are really committed to making a change in people's health. Next slide, please. So as I said, I'm going to focus less on the numbers, but just to continue, if you look at our net prices, and that is defined as the list prices we've taken across all of our drug portfolio and subtract out all of the 29.4 billion in rebates, discounts, and fees that we make to the supply chain, to payers, to PBMs, wholesalers, distributors, we actually showed a 5.7% decrease in our net price of the average net price of our products. Now, you may be saying to yourself as employers, did I see a 5% reduction in drug costs? I don't know, depending on the negotiation and the relationship you have with the plans and PBMs that you work with. Some or all of them may have been passed on to you, but certainly what we're hearing from patients, and obviously your employees are patients, they are not seeing that in a reduction in out-of-pocket costs. And there are some policies out there. The government is now trying to address that. They put some proposals which haven't really gotten anywhere yet, but to try to require plans to pass through those rebates to you as employers and to patients as well. But the other thing I think is important is we spent $9.6 billion in R&D spending this year, and that's obviously building to the future. If we look at what that was 4 or 5 years ago, part of those billions of dollars was investing in technology for an Ebola vaccine, which we ended up never commercializing in the US because fortunately, Ebola never became an issue. But it is that same technology and the science behind that we were able to mobilize quickly to create the COVID-19 vaccine that's out there now. So that's the importance of that investment in R&D. And that actually is more than we spend on sales and marketing. That's a common myth that's out there, is that, you know, you see all the ads on TV, and you're absolutely right. You know, a vast majority of them are about drugs with direct-to-consumer advertising. But despite that, we spend 106%, more than twice what we spend on marketing. At least that's a J&J number. I don't know if that represents the entire industry, but that certainly is numbers. And these are all audited numbers by our accounting audit groups. Next slide, please. This is, by the way, the 4th year in a row that our prices increase. So you can see, yes, our list prices go up, although this year less than they ever have, but the net price continues to go down because those rebates and discounts continue to grow. Next slide, please. But as I mentioned, despite that, if you look at the growth in premiums and out-of-pocket spending for patients, or in your case for you and your employees, they continue to go up. So that's what we really wanted to do with this transparency report several years ago, was to create an awareness, to shine a light on the entire ecosystem, if you will, of drug pricing. And I think it's been successful. You now see several pieces of legislation, both at the state and federal level, requiring transparency from health plans and PBMs to help to make them explain, okay, what impact did those discounts and rebates have on premiums? What are they doing on out-of-pocket costs? Where are they going? How many of them are being passed on to you as employers or to individual patients? Next slide, please. And obviously, as you know, out-of-pocket costs for your employees go up. I'm sure you all have seen data where their ability to either get the drug filled the first time or maintain on their therapy is, you know, extremely difficult. And there's studies out there. We pulled one fact here that, you know, emergency room visits, which are certainly more costly than the drug regimen, you know, go up 17% when copays are doubled. And that's just one example. There are volumes and volumes that show that lack of adherence and compliance to medication regimen has not only adverse clinical outcomes for people, but more importantly, adverse cost outcomes when you look at overall healthcare spending. Next slide, please. So, as I mentioned, our focus is creating a future where disease is a thing of the past. Next slide, please. In the last 5 years, we've spent $42.2 billion in R&D, which is 86% more than marketing as I spent. We've been increasing R&D at an average of 8.1% for the past 5 years. So despite our net prices going down 3 to 5% over the last 5 years, we were actually increasing our investment in R&D. And in 2020, our R&D investment of $9.6 billion, as I mentioned, was 106% more than we spent on our marketing and sales combined. And that includes all of our sales reps, all of our TV advertising, et cetera. Next slide. And as I mentioned, it's because of that we were able to quickly mobilize, not just us, the entire industry, to develop these vaccines and expand our manufacturing ability. We're able to have, because we have state-of-the-art technology for manufacturing, we were able to convert machinery over to producing vials of COVID vaccine. We have been bringing that to the public at a not-for-profit basis. And we're also looking at a lot of compounds to actually treat the disease should people get it. And I was involved in a lot of our global pandemic readiness team, and we have several compounds that are currently, they started with 400 and some compounds and they're down to 8. And 2 of them are J&J compounds that are being looked at as potential treatments for COVID or any other future COVID-like diseases or viruses. And we really need to try to understand what is that immune response should somebody get a COVID-like virus, and how can we mitigate or minimize the impact of that. And vaccine and prevention is obviously the best solution, but in the event that someone does get it, we can certainly reduce the severity and any morbidity associated with the disease, because we're trying to understand this. Looking at our products or our technologies that are developed for things like cancer, for autoimmune diseases, et cetera, redeploying that technology and that science to look at viruses and how it might mitigate the impacts. Next slide, please. And then about our promise for a healthier future for all. Next slide, please. I've been privileged enough to been asked to lead our pharmaceutical efforts on creating a healthcare, contributing to equity in health. As you all know, whatever issues manifest themselves in poor health outcomes tend to be magnified and have a disparate impact on diverse populations. And you may have seen that we made a commitment as Johnson & Johnson we're calling it, our CEO, Alex Gorsuch, calls it the race to health equity. And that really, we are investing a lot of money, but more importantly, we are partnering with HBCUs, with faith-based organizations, with a lot of the healthcare delivery customers that we have, with Amazon, with Walmart, to say, how can we collectively, first of all, identify what are the drivers that are causing these disparities, making sure that our clinical trials have an accurate and appropriate representation of the diverse population in those clinical trials, and also understanding insurance design and the impact on health disparities. Some of you may know this in looking at what happens with your employees, but I just saw data last week that the utilization of high deductible health plans is significantly higher among people of color than it is of the rest of the population, probably because the monthly premiums are lower. But then when it comes time in the beginning of the year to get a prescription filled because they haven't met their deductible, they find themselves with a very expensive bill to try at the pharmacy counter to try to get their prescription filled. And many of them abandon that prescription, and therefore that leads to poor health consequences and outcomes down the road. So all of these things, we recognize there are policies that need to be changed, but there needs to be an education and awareness. There's an inherent skepticism not just of clinical trials, which we know with Tuskegee and all the other things that's well documented, but of the entire healthcare delivery system. People of color don't get as much use of biologics. They don't get aggressive treatment as early as other folks. We're trying now to understand, is that because of lack of awareness? Is it because of provider bias? Is it because of transportation or housing issues? Those are all the factors that we're trying now to understand for each of the disease areas that we have data on to figure out how we can address those disparities and come up with not an equal, but an equitable outcome, health outcomes for people of diverse populations in specific disease areas. Next slide, please. So when we look at policies, we have established, this is our lens through which we look at everything. We believe that patients should have affordable access to appropriate treatment options and all sites of care. And as I mentioned on the disparities, that's a big issue. We believe that all treatment decisions belong in the hands of patients and their healthcare providers. And that may sound obvious, but for those of you who are not familiar with, and the next one, the clinically stable patients should not be switched on their treatments for non-medical reasons, unless it's a generic that's deemed interchangeable by the FDA. There's a process called non-medical switching, and it's really come to prominence in the last 5 years, where PBMs and health plans are saying these two drugs are interchangeable, and whichever I negotiate the best rebate, which by the way may not be the lowest cost to you as the employer, I'm going to switch stable patients from drug A to drug B. And then next year, if I get a better deal from company B, I'm going to switch it back to drug B. We talked to our benefit folks within J&J, and they weren't aware that that was going on, or even that it could be done. And we subsequently put a rider into our contracts with our PBMs and health plans that say, you cannot switch one of our patients, because I'm sure they don't come in and tell you, oh, we're switching from this SGLT2 to that SGLT2 when you buy this plan next year. The formulary is different. And they may not advertise that to you from a benefits disclosure. And it ends up with stable patients being switched. And there's all kinds of data and studies that show not only do patients and providers really not like it, there are poor clinical results as a result of it. So we believe when you look at policies, in order to support all those things, the marketplace needs to be fair and competitive. You may have seen things about bringing in international reference pricing and things like that. We believe, as you can see from the net price reductions, the marketplace is working. Competition is driving net prices down. And we just need to fix how those net prices manifest themselves in lower costs to employers and patients. We believe that we need to continue to support future investment. We've talked a lot about the impact of investment on the ability to respond to the vaccine, et cetera. We're now talking about clinical trials in cancer where cure is the endpoint. About responsible pricing. We are making a commitment to responsible pricing as a pharmaceutical manufacturer, but we think that needs to also carry through the rest of the system, from a provider perspective, from a hospital perspective, from a lab perspective. And we're asking for transparency and responsibility throughout the entire healthcare delivery system. And we really want to have, now there are these groups out there, ICER, et cetera, that are trying to determine what the value is. Well, they're very payer-centric and PBM-centric. We don't think all the appropriate perspectives on value are being represented, including the employer perspective. They don't look at productivity. They don't look at presenteeism or absenteeism. That's not even part of their calculation. And my team, Rebecca and Patty, who you work with, know that are really working to show and educate employers on your need to have a voice and a seat at that table and have those perspectives incorporated into these value assessment calculations. Next slide, please. So what we're looking for is, let's eliminate barriers to access. My team, we don't go in and say, eliminate barriers for the J&J products. We go in and say, patients and providers should have choice. We should figure out a system that allows them to have choice, and we should allow providers and patients to remain on drugs that are working or therapies that are working. We need to ensure, as I said, that those rebates are shared directly with patients or with you as employers. We need to make sure that we reduce the racial and socioeconomic disparities that are inherent in our healthcare system and have been for 400 years and continue to be today. And we want to be able to have an environment that preserves a reason to sustain the investment in innovation so that we can develop new curative technologies or responses to global issues, et cetera. Next slide, or that might be the last one, I'm not sure. Yep, so thank you. I look forward to, I don't know if we're doing Q&A now or after John does his presentation, but thanks again for the opportunity to share our information with you.
We will. We'll do Q&A after
Yep.
John
Yep.
shares his. Yep. Thank you. Please go to next slide. John Butler.
All right, well, thank you, Denise and John. What a great presentation you did. I hope I can address some of your comments and mine. If you want to go to the next slide, I'll begin by telling you a little bit about Edward Elmhurst Health. I'm sorry, can you hear me? Oh, there you go. All right, so I won't spend much time on this, but Edward Elmhurst, you can see at the top how big we are, or small, or whatever you want to say, but we're a 3-system hospital having annual revenues of more than 1.5 billion. We have more than 60 locations. A little bit of our bragging rights. We have been named one of the top 15 hospital systems by IBM Watson 3 years in a row. And we really do like the fact that we do provide advanced care in cancer, cardiac stroke, critically ill newborns. And like John was saying earlier about Johnson & Johnson, we do give a lot back. Also community benefits, charity care, you can read those numbers. And we also aim to deliver care that is seamless and personal. And like Joe said with US Foods, I try to steal from that and say, we're gonna try to deliver our benefit packages the same way, safe, seamless, and personal. You can skip the next 2 slides and it'll land us on some of the stats of what had happened in the last year. Oops, if you want to go back, please. Back again. Okay, so this will tell you a little bit about my employee population. It helps to know a little bit about the population to know what kind of things we've tried and what we can be successful in and what we can't. We have a total of about 8,800 employees, 88% of whom are benefit eligible. 70% of those do take our benefits. So that should be about 5,200 actual employees on the medical plans. And it averages a little bit above that 11,000 number for total members. So spouses and their children. We offer 2 plans, EPO plans. And if you were here, lucky enough to be here to listen to Ford talk this morning, he was talking about high deductible plans. And believe it or not, we did have one last year. We eliminated that plan this year because as a hospital, we see it on both sides. We know our employees couldn't afford the high deductible. We knew that we were seeing patients come in that couldn't afford the high deductible. And we were meeting them when they had put off care, and now when it was more extreme, you know, both community and the employee population as a whole. So we made the decision to get out of the high deductible healthcare business for those reasons. Another thing that it did for us is that it opened up allowing people to get their prescriptions without having to meet that deductible. I think John just got done saying it, that people do make their decisions based on their cost, immediate cost, and they can predict their cost of, you know, premiums or contributions up front, but they don't think about when they hit that hospital. And then when they get hit with that high deductible bill, they're just not able to afford it. And sometimes they make the wrong decisions based on that. So trend number 1 that we're doing is we got out of the high deductible healthcare plans. Interesting fact, at least to me, is that I was hired in 2005 to introduce the high deductible healthcare plan in 2006, which was very innovative for a hospital. So interesting to me that that lifespan has played out already. Some of our most strategic designs efforts have been related to our RX or our pharmacy spend. And here's some of our past design strategies. probably things that most all of you are doing. We did go with our generics and have them paid for by co-pays. We thought that gave low cost, predictable costs, which is very important to people. They want to know what they're going to spend by the time they get to the pharmacy. We also know not every drug is available in a generic, so we have co-insurances in our formulary brands, but we have lower minimums and maximums in our preferred brands. We hope we're nudging people to those that are just as effective but lower cost. Again, since we got rid of our high deductible health plan, we eliminated a separate deductible for those prescriptions. And we have done our version of narrowing the network, so to speak. We're not quite big enough to go out there and negotiate, say, with a close by pharmacy and say, this is what we want. So we did it in our own way. We engaged with our PBM to say, okay, if we're going to send all of our people to get all of their maintenance drugs from your pharmacies, what does that do for us? And what it did for us is it gave us the mail order pricing on all of our prescriptions, retail and mail order. Then we went into PBM changing. We do RFPs quite often, and we've changed a couple times. We've gone away from the old one, got back to it and things like that. And John mentioned this, restricting the formulary doesn't always work, but we did it kind of toe-stepping into it. We didn't go all the way that we could go. We went about halfway. It was very little disruption, and we always negotiate a grandfather clause. That means if you are on a drug, willing to try this, or if your doctor says you shouldn't, or if you have bad results, you can go back to the drug you were on. We just mostly do this for people who are going to go on to the drug. So that'll have some long-term effects, hopefully, meaning that it takes longer to see our ROI on that one. And then one thing that we're starting to do too is we're starting to transfer some of the upfront costs to people who have families. So it was pretty equitable in the past. Now we have a lower cost share with our employees than we do with the dependents that they have. And if we go on to the next slide, I can tell you what we're doing kind of today. One of our most innovative strategies, I think anyway, is that we've partnered with MBGH's Employer Evolution. And we did this for multiple reasons. We wanted to optimize our ability to contract with the PBMs. We wanted to get lower unit costs, total transparency, if that's even possible. And we wanted to direct some of the contract language and of course, increase our flexibility. How are we doing with that? So in 2019, I think we were one of the first to engage with these, with our vendor partner on this. And what we found out is that, well, I'll say that for next, but we anticipate savings of over almost $8 million now over the next 3 years. And that's because we're beating our estimates on the first year already. So you can see how it breaks down through 3 years. Again, through MBGH, we got this vendor partner who then presented our RFP for us, negotiated our contract, and we are quite happy with it, as you can see here. Why were we happy? Well, we found out that our benefit consultant, who was very good, but had a little bit of a conflict of interest. We were always presented with their co-ops. There was a hidden consultant fee in the contract with the pharmacy, hidden only because, I mean, we could find it and stuff like that, but it wasn't brought up to us. So now we know there's a fee. We were told that up front. We know it's 2/3 less than it was before. So again, happy with that. We got to direct some of the contract language. Again, you hear people talk about rebates and wanting to get all of them back. Well, the ones that we know are rebates, we're supposed to be getting 100% of them back. And this is why I say we're beating our estimates. We're getting more of the rebates back than we thought we would. So we're at 28% this year, whereas in the past year it was around 24%. So I'll talk a little bit later about the flexibility that I'm seeing with it and things we can do in the future. We didn't leave our PBM out of it. We did, again, use the baby steps. We went to their performance select drug formulary, which disrupted about 300 people. But it resulted in $600,000 in annual savings, so we couldn't leave that on the table. And again, we did have to do something. The results, is it paying off? You can see below, it's not fair to give you total cost, but if I break it down by PMPM, you can see that for the first time, and as John predicted with some other efforts, we're seeing our PMPM go down in 2020, 7.4%. So I'd say that it did have some good effects. That's not all we're going to do. So if we advance to the next slide, I'll tell you what's on our horizon to do with the pharmacy. We're going to further probably restrict our formularies. There's one more level available through our PBM that should result in just over $200,000 additional savings. We'll take a look at that. The advantage I do have is that I can have doctors and pharmacists look at that before we make the change. And then once that's done, we are going to take it to our, again, hopefully the person who doesn't have a conflict of interest, and have them take a look at it and pick out other things to further reduce it, or excuse me, restrict it for people. So lower cost of alternatives are just as effective. We'll proactively, this is something new that came to me from MBGH. I never thought that I had to start looking on the horizon. I thought it was enough just to know what happened in the past or know what's going on now, but we're gonna start reviewing very aggressively the drugs in the pipeline, so we won't be reacting to the changes when they're made. We'll kind of know up front when they're coming, and we'll do that with our pharmacy consultant partner. Internally, because I do have pharmacists on staff, we're going to try to start negotiating our own specialty drugs with the manufacturer and be a supplier for our employees. Again, you'll hear some of the bigger companies can go directly to manufacturers and negotiate those costs. So this is our version of that. We're going to do it through our pharmacy. Not everything worked out for us. I told you a little bit earlier that we investigated narrowing the pharmacy market down by going directly to some close by pharmacies. We found it probably at our size right now with everything we negotiated in the past wouldn't be as viable to do. So the next slide, please. Okay, so this is the one we're going to skip. And if we can go to the next one, just keep looking at these calendars, knowing all this stuff was going on so fast. The challenges started after the March. You know, we were fighting for PPE. Somebody mentioned that before. We had some healthcare systems talking about this. When we were doing screening requirements for our employees, we were also having to come up with them for people outside. So as you can see, all this stuff is going on, and our employees were getting competing messages. Things were changing every day with COVID and stuff like that. If we can go to the next slide, just real quick, I'll show you what this all boiled down to for us as well as the other healthcare systems that you had seen presentations from. You've got the worldwide data, the US data, and then you see our own data there. So these are statistics from one disease that never even existed a year ago. And then if we can go to the next slide, why would I even bring this up? And I intended to spend more time on it, but I know we are trying to save some time. Why did I even present any of it? We all knew what was going on. We probably are all happy to see it in our rear view mirror, most of it anyway. But I just wanted to present a case to show you that one thing that COVID and the pandemic has taught me is that I'm very much competing for my people's attention, trying to get them to pay attention to wellness programs and get excited about open enrollment when they've got a lot of other things going on, more than ever in the past. So how did we address that? Believe it or not, in a healthcare system, or in my healthcare system, we did focus groups, things to the Rock Group, and we found out our employees wanted hard copy everything. If I put something in electronic form and sent it to them, they thought I was hiding something. They wanted hard copy, hard copy, hard copy. Well, overnight that changed. And so I'm presenting this as a trend towards technology that we're now adapting to and adopting and embracing. But our employees, some of them weren't going home at night because, first of all, they had to set up things in the next morning. Secondly, they were afraid to infect their households, their parents, their children, all this stuff. So they were going to hotels. So I could not send anything to one location. They don't sit in cubicles. They don't sit in front of a computer every day. So how did we handle this? Well, we engaged our Rock Group partner, and we decided to do something electronically, an enrollment guide that was shorter. And I don't know if you were all like me, but I thought the QR codes, I didn't even know that's what they were called, but I thought they went the way of the metric system. I thought we killed them, they weren't coming back, but they're back bigger than ever. So much so that you probably see them in your supermarket now and all this stuff. So the way we were able to address this competition for communicating to our employees is we presented them with a QR code that was sent to them. They can take their smartphones, scan it, and it takes them to this enrollment guide that's about a 30,000 foot level. However, if that's good enough for me, I read the enrollment guide. But if it's not good enough for the next employee, they could click on links that would take them a deeper dive into the details. how much do we pay for prescriptions? How much do our rates cost? Who do I contact if I need more information? That they simply had to push on the phone number and it would dial their phone for them. They'd push on a link to the providers, it would contact the provider, and then they could ask some of their questions. This was just innovative for us. It's so innovative, and probably the only thing that I think I can say I'm leading a trend on in our organization, because I've had other people tell us that, I'm going to show you on the next slide that when people want a resource, they want it easy and they want to get to it right away. So this was our answer to that. And other parts of our organization are now finding that they can jump on the bandwagon with that. So here, my heart dropped when I heard Ford mention how video appointments skyrocket. And I thought, yeah, I'm going to talk about that too. And then I heard him say they came back down to 15%. And I thought, uh-oh, am I saying this is a trend and it's already going away? But I think it's still there in some form or another. Video visits, we started those way before COVID, and we couldn't give them away. In fact, we tried to give them away to our employees. And it's funny, one day I was bragging that we were able to add those to our benefits, and two people on my team, of a team of two, said they weren't using them. And I said, why? And they said, well, it isn't convenient as you would think, because I have to put my kids in the car anyway and go get their prescription. I might as well just go to the store and do the visit in a walk-in clinic. So I thought, I never thought of that. It seemed so smart and stuff, but like I say, couldn't give them away for free, then tried to add them to the plan for a cost and thought they had died a death. But overnight when COVID, I think we all experienced this, they came back, roaring back, they had to. I think I left it on here only because I think in some form or another, they are going to remain, even if it is the 15%. And we're all going to have to decide how to reimburse for them, what treatments are appropriate for them. Is it just behavioral health? Is it just a sore throat, pink eye, whatever? But we're going to deal with those in the future. So we're looking at that in our plans. And sadly, but I also say happily, one thing that COVID taught us all is that behavioral health, it was kind of hidden out there. Everybody said it was about 30%. Overnight, it skyrocketed to 60% of the population was dealing with it. Nowhere more than in a hospital setting. Again, I told you, people weren't able to go home to their families for fear of infecting them. We didn't know what we were getting into. We didn't know how bad this was going to be. Anything like that. So we had people literally walking out of rooms, just breaking down. And these are people who never thought of themselves as weak or needing help. They thought of themselves as people who delivered this help. And I'm sure, even though it may not be that extreme for your organization, I'm sure you're all dealing with it too. But what it brought to my mind, and we heard a couple people talk about this earlier, is that one size no longer fit all. And also, you couldn't just deliver it in one way. I learned that if I'm a doctor, I want to talk to another doctor that knows what I'm going through. If I'm a nurse, I want to talk to a nurse. So it's segmented in that way. No one person wanted to dial the EAP. Some wanted to go to websites and look at videos. Some wanted to talk to coaches. You can see on this slide, we added healing teams, which were part of our pastoral care. They were part of our counselors at our behavioral health hospital, and just cohorts of these people. And they would just sit in rooms and walk through the hallways and hope that somebody would think to talk to them. And many times it wasn't that they would talk to them. They would come to talk to them about a friend and then start realizing it was them. But these are not going away for us. We've gotten rid of the healing teams. They're not as necessary right now, but we've morphed them into crisis support staff. We've inserted behavioral health into our wellness program, which, shocking to us, wasn't advertised very well, but it was our most utilized resource, partly because I think our people found it to be where it wouldn't get back to the employer, partly because they had so many different methods. They could do videos, they could talk to somebody, they could go at their own rate, they could do 10-minute breathing exercises, 8-week courses, things like that. So again, many people have talked about it. I think it's going to stay on our horizons for a while, but we know it turns into, if you take care of this, you take care of your absenteeism, your presenteeism. So if I was keeping track, and I'm going to wrap it up now, the trends that I see for us especially, and I'm cheating, I'm reading my sheet here, is we got out of high deductible health plans, and I was happy to hear Ford say that either you're maybe getting out of it or you're just not increasing them. So the reason we got out of it, and what it helped us do, is it helped us do multiple things: reduce the cost for employees, That, along with us narrowing our network and talking to an independent contractor for our RX, those savings were enough that this year we were able to reduce costs for about 76% of our employees. We started going with transparency in our RX program. We did salary banding. I know that we were told it was about a third of the employers that were doing this. We joined that trend. Let's see. We started, I think we're going to deal with video visits, and behavioral health is a thing that's probably going to be with us, sadly, for a while. So with that, I appreciate the time you gave me, and I thank you, Denise.
John, fabulous presentation. Thank you so much. And if we could bring John Hoffman back too, we could probably go to gallery view so we can have a discussion. Lots of questions coming in while you were speaking for both of you. But before we dive into the audience questions, I have a couple of my own. I've been taking notes. I'd kind of like to go back to the high deductible health plan. You know, kudos to you, John, right? For changing, getting out of that, recognizing the need for that. And we surveyed our members late last year, and 81% of them said they have high deductible health plans in place with HSAs. Also, 79% of them have PPOs. What I don't know is, John Hoffman, to your point, are the HDHPs being accessed more by persons of color, and right, and then so the lower lower wage workers, based on the statistics that we've been seeing. I'm not. This is not me.
There is
a prejudicial remark. It's what's been reported out to us, right? So, yeah.
Yeah, so I believe it's the Pioneer Institute. I will try to get this to Rebecca to get to you to share. The Pioneer Institute looked at that, and they said there is a disparate use of high deductible health plans among lower income and then also, you know, diverse populations. So, and it's for what John said. They're looking at the predictable monthly cost of premiums versus what's going to happen at the hospital, emergency room, pharmacy counter, you know, whatever. So
right. But another way for employers to kind of slice their data, right? Yep. To see if they're providing equitable benefits to their members. And so, John, a question that came in, and you did, I think, address this, but I'm going to ask it anyway because it's a bit more direct than the response you gave later in your presentation, which is how much of your costs and premiums increased from the high deductible health plan option?
What we did is, to John Hoffman's point, our HMO was the lowest cost plan that we had, and then our high deductible health plan was the second highest cost, and then we had another sort of a PPO plan for those people that are not in our network. So if you went down to the new EPO plan that's more exclusive and just our network, it went down about 26% for those people. So you have a choice of then taking an EPO plan where you still can go to our medical providers network of, and then there it probably stayed the same for you at that time.
Okay, thank you.
Mm-hmm.
From the perspective of equity in healthcare, and J&J is looking at clinical trials, right, and making sure there's diverse population in that. You mentioned educating about high deductible health plans. You also talked about partnering with others in the community. What else can pharma do, and how do we bring this together with employers? Because it is about so much more than educating on HDHPs, right?
Yep, sorry. No, actually, if you look at our Healthier Communities pillar of our Race to Health Equity, there are 4 pieces. The first one is appropriate representation in clinical trials, as was mentioned in the question. The second one is focus our research. We do I'm not talking about our clinical research, I'm talking about our health outcomes research that we all do a lot about to say, what happens with copays on drug costs. Focus them on understanding what are the disparities, what are the social determinants of health, and what are the drivers of those. And so that's something pharma has the ability to do that. We have access to the data, and so we are doing that. The third bullet is to convene stakeholders. And once again, my team works with patient and provider advocacy groups. We work with employers, as you know, but we're also reaching out. It's truly a community effort. It's working with not just other pharma companies, it's working with health systems, it's working with companies like Amazon and Walmart who have access to people. Is there a way, if food deserts is a problem that creates a disparity, well, there's an Amazon truck delivering a box every day on every porch. Is there a way to incorporate them? And so that's the third piece, is convening those stakeholders. And sometimes we're going to be the leader, sometimes we're going to be a participant, but it not to be corny, it takes a village to address these issues. And we want to set up test and learn opportunities in communities and focus on a specific issue with all of the appropriate, should we be doing prostate screening or talking about prostate screening at churches on Sundays or whatever, or the barbershop or whatever, which is where people go and listen. And then the fourth piece is to develop capabilities. So maybe we as a company or as an industry need to develop transportation services to bring the site of care to the inner city as opposed to expecting the patients to go there. So those are the four things that we're focusing on that we can do as a pharma industry. And I think it's fairly consistent. The feedback we've gotten as I talk to other people around this is most of the pharma industry is trying to address the clinical trial representation first, and that's fine, but that's only a part of the solution. And we're really trying to do the other three. I hope that answers the question.
It does, and thank you. Yeah, great work that you're doing. John Butler, I want to congratulate you on that QR code and the communication that you created. I mean, just so brilliant, like truly creative of you to do that. And I'd like to hit on a piece that you talked about with the behavioral health, where you said, it wasn't really front and forward, but people still managed to find it. Is there anything that you're doing now to put it like more in the face of?
Yeah, a great question, Denise. We learned a lot. First and foremost, this is probably self-serving, but when we came from a healthcare standpoint, we were told there was not enough resource out there for nurses and doctors during this whole pandemic thing. And it's like we scrambled. Then I was told that the sort of the help that I had through my healthcare plans wasn't enough. But again, it was already introduced into the wellness plan. But when we were surveyed out there, we found out the problem wasn't not enough resource. It was too much, too confusing. The second thing we found out was the things that people were attacking were the things that were getting utilized the most and being the most helpful. That's not to say the other things weren't valuable. I was willing to play fair and say, it's to me, the question of having enough out there and the different varieties of things and stuff like that. So now what we're doing is we're kind of on the back end trying to say, how do we organize it and which way do we organize it so that a person knows if I'm just having a slight anxiety attack, I may need this resource. On the continuum of care, oh my God, I'm in desperate need and I need this resource on this end. And how do I get to it easily? Believe it or not, when a person's suffering, they're telling me, well, it's so hard to navigate. And I'm like, what's so hard? It's right there in front of you. Well, they don't even want to have to put in another password. They don't want to have to dial a phone and stuff like that. So anyway, to answer your question and wrap it up, we're trying to put together that continuum so that even we understand it and we can hear from a person however we hear from them and say, here's what you need. We're also getting our vendors and our internal resources together to say that if you contact me and you really don't need me, I can soft transfer you or tell you what resource you need and get them to work together. So that's what we're building on now.
Great, that's fabulous to hear. Yeah, makes such a difference for the members when it all works seamlessly, right? I know I don't want to make additional phone calls or send emails and try and connect the dots for myself. No. So we've got an interesting question out here, and this is, have you have you entertained addressing digestive health in an effort to reduce high-cost GI meds? And I would expand on this to say, you know, how are you addressing chronic disease, and is part of your goal to reduce meds? Is that ever a goal that you're setting? So I want to see someone become healthier and reduce the number of medications they're on, reduce the high cost drugs that they're having to take. Do you put that hat on when you're designing programs or looking at vendors and what they have to offer?
Yeah, Denise, if you're asking me, I will say that it's something that when you put these presentations together and you're thinking of trends, I mean, I could go on forever, and I always usually am taking in the knowledge and giving it, but I thought of one thing I did put in this is that it's funny to think about us being a healthcare system that we never put it together. And somebody said this earlier, that if I'm going through, say, diabetes, and I have diabetes, we wanted to treat the diabetes, but we didn't recognize that that person may have a depression. And that makes that person different than the person who's treating diabetes without it, which makes that person different than the person who has a financial constraint to it too. So if I can say it, I guess I'm just going to, and you can beat me, but we're partnering with one of your partners in Spirit to now address that, because I've been waiting for a long time for us to address it internally, and everybody says we can, but we don't have the resources now. So we're going to do the next best thing. And that is, again, partner with an outside vendor. And I hope Jason doesn't mind me saying this, but I heard him talking about innovative vendors, and I probably didn't get that right. And again, we're too smaller. We just don't have enough voice or time. So that's what we've done, is we've done the same thing that the bigger people are doing, just by finding the right vendors. And if that's even too hard, I don't even have to do that. I just have to come to my friend Denise and Cheryl and Dawn and all of you guys, and you find them for me. So that's what I'm personally doing. So.
Thank you. Good. And you're treating the whole person, and that's the perspective. And
we're going to get there. We aren't doing it right now, but we're getting.
But you're working on it. Yeah. John Hoffman.
Yeah. So from a healthcare company perspective, because I won't say a pharmaceutical company perspective, as I mentioned, as J&J, we're committed to a world without disease. So in addition to doing pharmaceutical research to find ways to stop the progression or eliminate the disease immediately, we also have J&J, we have a consumer sector and we have a medical device sector. So we are now partnering with systems with Ever to look at, first of all, we have a Human Performance Institute, which looks at optimizing people's diet, optimizing their health, their exercise based on their lifestyle, based on their specific needs, their family history. And then also to say, if that doesn't work, there may be, what's the trade-off? Because especially in Crohn's disease, there's a time when you decide surgery versus continued medication, not just from a cost standpoint, but from an expected outcome standpoint for the patient. So because we have all three of those pieces, we're now trying to put together an education, monitoring, screening, diagnostic program to say, how do we optimize that, looking at behavioral change, lifestyle change, pharmacological treatment, or surgery. And sometimes, obviously the first one can stop all of it, but in the event that it's already too late for that, what's the better option of the other two?
Great. Well, thank you. John Hoffman, we greatly appreciate Johnson & Johnson and your transparency reports. They are influencing the market, and we hope you'll continue to bring those forward. And John Butler, thank you for sharing what you're doing in Edward Elmhurst Health. I love watching how you're evolving with the times, and continue to work on improving the health of your employees. And so I will now turn this over to Cheryl Larson.